Hello everyone. This will be a short introductory slideshow on the stab incision glaucoma surgery, or SIGS or Sigs, and this procedure was originally introduced by Susan Jacob from India, which I think is a really brilliant procedure for a low-cost, high-volume solution to glaucoma surgery. As with most glaucoma surgeries, we start with mitomycin C injection. Obviously this is not mandatory, but I have started using it and it works to good effect. I normally use a 40 micron injection or a 0.2 ml injection from a 10 ml 2 milligram solution, and here you can see I've injected from the fornix side, and I'm just sweeping the mitomycin C to all the areas where the bleb could possibly go, and I want to just create nice flat conjunctival area to work with. The first step is essentially to get viscoelastic into the eye, just underneath the area where you will be making your entry point into the eye, just so that you don't have collapse and damage intraocular structures. Just using a 15-degree blade, and here we're using some Provisc. The main and important part of the procedure is then to make a stab incision, and this essentially creates the tunnel that acts as the drainage device. So here, as you can see, I'm making a conjunctival fold, so my entry point through the conjunctiva and then through the tenons is quite a way back, and I'm hitting entering the sclera about 1 millimeter behind the limbus, and I target a half depth sclera and corneal path, and then I want about a 1.5–2 millimeter tunnel, and this ensures a tight seal without any punches. Next up is the Kelly punch, and standard Kelly punch is used. As you can see, it's quite easy to just enter where your stab incision was made, enter into the eye, and in this specific case I'm punching once and just checking that I actually took a bite. And I made a second punch. Depending on the length of your tunnel, 2 or 3 punches is the norm. But you then check the pressure, and how you do that is you just essentially hydrate the anterior chamber, and as you can see, there's aggressive fluid through the tunnel. All my viscoelastic has exited the eye. You can see that the anterior chamber is remaining nice and stable, and here I'm just checking the pressure of the eye. So my end point of filtration is a nice soft eye, but with a formed anterior chamber, and that's important. Soft eye, formed anterior chamber. Because I've checked my pressure and I know the end point of filtration is perfect, I just then suture my small little conjunctival wound, usually with a double throw with a 10-0 nylon, and this is essentially the longest part of the procedure for me usually. If you feel that you have overfiltration, you can actually just open up the conjunctiva there and put a suture through your scleral wound or scleral entry point, and if you feel you have underfiltration, then you can just go in with your Kelly punch and punch again. So I use 10-0 nylon. These little nylon sutures usually tend to fall out themselves, and I prefer nylon above Vicryl just purely from a scar tissue formation exercise, I thought. And this is then essentially the only suturing during the entire procedure. and then lastly you just form your bleb. So this is a very nice technique because there's no active dissection of any tissue. There's just normal dissection or hydrodissection of your normal tissue planes, and as you can see, here's a nice big large bleb forming just purely through the filtration that you are overhydrating the eye. There you can see slight pupil stretch, and as the AC flattens the or shallows rather, the pupil gets smaller, but the AC is still formed and the eye pressure is good, as we confirm here with a formed anterior chamber. Beautiful bleb with no dissection whatsoever. This case had 2 punches. Here's just another example of a nice bleb forming, and in this specific case there was just a single punch with a Kelly punch. You'll also notice that I haven't made any PIs, peripheral iridectomies, in these surgeries. You can enter through your tunnel and through the scleral port if you would like, under vision, and create a PI if you wanted to. So as you can see, nice short introductory video. It's quite easy to perform SIGS, stab incision glaucoma surgery, and you just put your viscoelastic in, make your stab incision, make your punches, check the pressure, punch again, or if you're really worried about overfiltration, you can actually just open your conj and put a suture in as you would with standard technique, or even through your conjunctival penetration, and then you just end with forming your bleb. Thanks so much.